Thank you very much, Raquel. So my name is Rakesh. I'm a professor of mental education and honorary consultant nephrologist, and I'm going to talk about clinical diagnostic decision making and when it hits the fan, some of the moral, ethical and legal issues that are relevant to healthcare professions, educators. As an outline, I'll start by saying what clinical diagnostic decision making is, why it matters, and then move on to what a fan-hitting moment is in this context. I'll then outline what we mean, or we could mean, by ethical, moral, legal issues against this backdrop in an era of AI, now that everyone is using it, or as many people as put their hands up. And then I'll quickly move on to who the public think is accountable when a doctor uses AI for diagnostic decision making and it goes wrong. I think who the public think is one thing, but then there's what the law says one is liable for if things go wrong. And then I'll try and round up by going forward, outlining some of the things that we need to think about as healthcare professionals, educators, against all of that. So the first thing is, I'm not an ethicist, I'm not a philosopher, and I'm not a legal specialist. So I come at this very much as a clinician, as an educator, and as a researcher. But even cast that aside, I'm going to try and present this through the eyes of what a citizen would be, as a husband, a dad, a son, a brother. And I think that's important because it's really, for me, matters who's not represented in this room, because those are the recipients of what our outputs are, and they are looking on to make sure that we solve this challenge now. So what is clinical diagnostic decision making and why does it matter? So let's start with why it matters. In medical education, those of you I know who are first here, you'll start realising that terms are used and they often mean things in different contexts, but more importantly, they're often multifaceted constructs. They're made up of different components, but very few of us would argue that in terms of the output of a training program, you would expect your healthcare professional to be able to make an accurate diagnosis and/or an effective decision. However, it's not as simple as that, and this piece of work by Meredith Young and colleagues demonstrated that if you ask a group of people what clinical reasoning is, you'll get over 100 terms, and that's just the reasoning part. Forget the decision-making part, and there's a wider body of literature in psychology that probably has equally a larger number of points. I draw attention to this because if we can't define the term and what we mean by it, when we're using AI for it, how do we know what it is doing and which part of it it's doing? So for the purpose of this presentation, I'll define it as a series of tasks, and those of you who are involved in training healthcare professionals, usually examples of tasks would be history taking, physical examination, differential, etc., etc., with a clearly defined performance outcome, which you as the educator will know, and that usually takes place within or across a series of stages within the clinical inquiry. That's relevant for healthcare professionals educators because we already develop activities that foster the skills necessary for either consultation skills or communication skills so that healthcare professionals are able to do this. Now, if AI now is doing part of this, that presents a challenge for us right up front, because when we're trying to assess performance, how do we know which bits are the learner and how do we know which bits are the AI? And more importantly, what are the long-term implications for skill acquisition and skill decay? And these are conversations that are happening now as more and more evidence comes out that the use of AI induces metacognitive laziness, etc., etc. But even putting that aside, most of us would contend that if the tasks are authentic, they give our learners the opportunity to make a real-life, complete a real-life task in authentic settings, and you're responsible to do something. Now, all of that should be situated in a context. And I think the word context can be overused in medical education, but those of us who perform diagnostic decision making, we know what context is. It's in that moment, with that particular task, that patient, with our team, etc., etc. But the thing that often is missing or is implicit and not explicit is that that task operates within frameworks, moral frameworks, ethical frameworks, legal frameworks. And again, if we are isolating those frameworks from the task, I would question, are we actually teaching the task in the way that it needs to be completed in practice? For me, those frameworks are inherent within the design of the task. And if they're absent, I would argue that are we just teaching the learners to pass a problem-solving question for purposes of exam or OSCE, or are we actually preparing them to do the task they need to do when they're in clinical practice? Likewise, you have to be responsible for something, and I think it's that notion of responsibility that again cannot be divorced from the task, because whenever diagnostic decision making is happening in practice, there's always another clinician or there's a patient, there's the rest of the team, and then there's a system to think about, and all of those have implications, consequences and ramifications if you are getting it wrong. Again, if AI is performing part of that task, that is now causing confusion, and it is a cause of concern for those of us in the profession. What happens when things go wrong? So fan-hitting moments describe situations, as I said, when things go wrong, but then they cause trouble for the person or a person, be that the patient or the healthcare professional or the team within a system, and the real fan-hitting moment is when it snowballs out of control. And this is serious. Even before the pre-AI era, when there was a diagnostic error, it was always a cause for concern, and often in the media glare. So this is the front page of a tabloid newspaper from the UK, and it's devastating for the patients, their carers. They obviously have a sense of injustice, which they want to pursue. If you're the doctor at the end of that, you are often in the middle of either misconduct or criminal proceedings, and you see your life and your livelihood crumbling in front of you. This is not an abstract concept. This is real, and the learners fear it, and I, as a practicing physician, fear it for me in my practice. But what the era of AI has done is it has changed where that sense of responsibility lies. So this is another case that was talked about in our AI symposium. In this case, you have a child who unfortunately took their life by suicide. It became apparent that the child had multiple interactions with a chatbot, including in the moments before they claimed their life. That is going through a legal challenge, and the judge throughout the case that the chatbot did not have First Amendment liability and more importantly, that the developers did have a duty of care to protect its users from harmful or hateful speech. But the real fan-hitting moment is when then you start working out, like in all investigations, what else was implicated. And the sickening thing in this case was that the chatbot was linked with another chatbot for another case of suicide in the UK, and you can start seeing how the glare is extremely apparent for the developers, those involved, so on and so forth. So I've tried to simplify this by picking out 3 terms that I think are important, 2 of which I'm not going to deal with because, as I say, I'm not an ethicist, I'm not a legal specialist, but I'm going to deal with moral responsibility because I think that's something that we should be interested about as educators or clinicians. And for you to be morally responsible for a decision or an action, 2 conditions have to be met. The control condition, i.e. you have to be in control of that decision or action, where the loss of that control is not due to recklessness, and what's known as the epistemic condition, and that means that you have to have sufficient understanding of that decision or action and its consequences, and not having so, i.e. being ignorant of it, is not due to your own negligence. Now, how do we put those abstract concepts into practice? Well, let's take this study, and now that AI is being used for clinical decision making, you could apply this sort of lens to any study that you may have seen published. I've just picked this one from the UK, and in this particular study, a group of researchers were trying to validate an AI decision-making system for the management of sepsis in an ITU setting, and sepsis, for those who may not be clinical in background, that's when infection is sufficiently severe that it spills into the bloodstream, and it can lead to a rapid deterioration in health, requiring either intensive care or cause risk of death. When you look at the premise of this study, I think it's interesting because the idea was that clinicians are prone to distraction on the ICU, or are prone to clinical inertia, whereby whatever the chart says on the previous, we just continue it in terms of the dose of drugs or whatever. It was proposed that AI, being ever vigilant, you can program it, and it had functionality to make changes every 4 hours to drugs or whatever. What was interesting is when you drill down into that study, the outcomes that the AI was producing was a combination of what had previously happened in terms of ways in which patients were managed in that system, and half of it was through random cause and effect, however it was programmed. But what I found most interesting, and perhaps we can pick up in questions, is that a cognitive part of the diagnostic decision-making process was handed over to the AI, and that's the interpretation of clinical data. Now, if you look at that in research in its entirety through, as I say, the lens of ethical and moral issues, I think actually saying that the clinicians were morally responsible was difficult for me to take that stance for several reasons. Now, sepsis, those of you who have clinical background, you will know that actually the evolution of it is quite uncontrollable. It's not necessarily in my control as a physician as a consequence of any of the decisions I've made. It just gets worse, and it can get worse really badly. But we also know from the pandemic that new bacteria can emerge, and actually different organisms will respond differently to different treatments. And actually the most important thing is actually how the patient comes into that illness and what comorbidity they have as to how well they might do after a spell on an intensive care unit. Likewise, in terms of programming of the algorithm, it's quite difficult to program sepsis as an algorithm and how it may happen on an intensive care unit. And actually, a lot of the programming is actually, you can't specify a priori. So the algorithm, I would argue, to say that I'm responsible for an algorithm that's making a decision there that actually is coded imperfectly, I think I'd be quite upset if I was held responsible for that. But those of you who have treated sepsis, and as a renal physician you sort of know that fluid balance and how you make decisions around intravenous fluids, you know that you can't measure some fluid loss through sweating, you can't capture that electronically, yet the system was making decisions around how much fluid should be given, where by just eyeballing the patient would say, actually they've got enough fluid, they're boggy already, we shouldn't give any more fluid. And likewise, I might see a result that's erroneous, I might ignore it because I know that the potassium has just flowed out of the sample, let's just do a repeat. The AI wouldn't do that, it would just make a decision based on that. Likewise, saying that a clinician would have sufficient understanding of that algorithm would be difficult, in my opinion, to take for several reasons. Again, we've had a 2-day symposium. Most people have said, we don't even know the black box of these algorithms, so how I could have sufficient understanding of that and then be held responsible, I think, is difficult. But likewise, there's variation of treatment in sepsis across me and my colleagues, across me and my other specialties, between hospitals, between systems, and different parts of the team are responsible for different aspects of care. So I might prescribe the treatment, but a member of the nursing staff may actually put the fluid up. Who's responsible then in terms of if something goes wrong? And likewise, I've already mentioned the algorithm in terms of its decision making. The developers can't even tell us why the decision has been made, so to make me responsible or for having understanding of that decision, I think is difficult. So moving on to who the public think as to who is responsible, I think this is really interesting. I've just picked this one study to highlight what might happen if something were to go on and the public were asked. So this was an online experimental study. It's a US study of 2,000 participants, effectively jurors, or who could be called up for jury service. Participants were presented one of 4 scenarios. It was a breast cancer drug. One standard treatment was 900 milligrams. I think the non-standard treatment was 4,500 milligrams. And effectively, they were looking to see whether the clinician followed non-standard treatment or standard treatment, and then in all scenarios, harm was caused to the patient, and then the participants were asked, do you think that was reasonable, or how reasonable was their decision making? And what I find fascinating, if you look onto the graph, if you look at the lightly shaded grey, effectively the general public will think if you follow the AI, whether it's standard or not, well, that is reasonable. If you don't follow the AI, even if it's standard care, that was seen as less reasonable. And I think that's really, really important given what I've just told you, that the public already think that maybe we should be following AI. Who is accountable as the law stands? So in the last moments, it's the doctor as I understand it. And this is important because this will vary across jurisdictions. So when you start looking into these things, it always goes back to law, which is why there is now a tension between making sure we know as physicians what the law says in our various jurisdictions as opposed to what we think it is, or what our regulator or what our Royal College may say. It's actually what the law is in your jurisdiction, and then working out for me in the UK, well, what is my jurisdiction? Is it EU, is it the UK, and where is it? And then you will start to see that in terms of legislation, the conversation is about regulation, that's slightly different, but in terms of legislation, it is a lot far behind, forget even AI, other technologies, and it hasn't been updated, and I think that is a real issue. It's a real issue because of what is known as a liability sink, or a phenomenon that's known as a liability sink. So effectively that is a person who absorbs the legal liability that's generated by actions of an electronic device. Now that is jargon, that is legal speak, but as AI is currently constituted, it would fit that definition, and it's usually the person at the end of a long chain of decision making. So it's not necessarily the person who made the decision to buy the software in the first place that we were then told to use. It was me because I use that software and I am closest to the person who's suing me, and that's usually the patient or their relative. And that's why this is a real issue, and it's a real issue now. Going forward, what do I think we need to think about? So there's a number of things. I think in terms of policy, we do need clarity around the ethical, moral and legal frameworks relevant to our own jurisdictions in healthcare, so that us as educators then can think about what advice we give to our trainees and how we give guidance to our learners who are in hospital or community care settings where they may be watching practitioners apply this advice. I think there needs to be some form of consensus, again, between educators and clinicians around the relationship between AI and the physician or the team and how it's being used. But really what is important at an institutional level, that there's consistent advice and guidance that goes out to all staff, and that then these then feed back into education and training programs. In terms of current practice, I do think there needs to be a revisiting of the conversation of how we make explicit our diagnostic decision making and how it proceeds through a consultation. That's the unit of intervention that our learners will see. They won't understand it, they'll just see what we're doing and our behaviours and what we say, and we need to make explicit how that works. We have to accept that really when it gets down to how these things are programmed and how we understand the way in which we come up with the decisions and diagnoses we make, that happens very fast through an intuitive system, but obviously there's an analytical system that we use, and if we don't make these things explicit or don't think through how we come up with our diagnoses or decisions, the learners won't see that, and all they see is the output, and that's the problem. I was always told to show my working out when I was learning, and if we're not showing our learners our working out, what are we showing them? And then finally, in terms of research, I think it's really, really important that, as was said in the AI symposium yesterday, there's an opportunity to research on AI, but there's an opportunity to research through AI how we make diagnoses, how we make decisions, how we then construct the training data that then feeds back into the algorithms and the technologies and tools we use through real patient cases. And then ultimately, I think, as was exemplified yesterday in the opening plenary, investigate the impact of all of this on how it affects our patients, our teams, the systems, and the countries we work in for benefit. Thank you.